Today I'll be talking about von Hippel-Lindau disease and specifically focusing on the neurologic and otologic manifestations of this tumor suppressor gene syndrome. So I have no disclosures to report. First, we'll go over the history, the biology, and the clinical manifestations of von Hippel-Lindau disease. Then I'll also talk about specifically hemangioblastomas and their management, and also discuss endolymphatic sac tumors which occur in this syndrome. So von Hippel-Lindau disease is a tumor predisposition syndrome which occurs in about 1 in 39,000 individuals. It has a very high penetrance and can lead to tumors of the central nervous system, including endolymphatic sac tumors, CNS hemangioblastomas, which include retinal hemangioblastomas, as well as spinal cord, cerebellar, and brainstem hemangioblastomas. In the systemic side, these can lead to pheochromocytomas of the adrenal glands, renal cell carcinoma of the kidneys, pancreatic islet cell tumors, and in men, epididymal cystadenomas and broad ligament tumors in women. So the name von Hippel-Lindau is actually from two individuals. Von Hippel was an ophthalmologist in Germany at the University of Göttingen, and he was the first to describe a retinal hemangioblastoma, which at the time he described as a retinal angioma. The other part of this name, Lindau, came from Arvid Lindau, who was a doctoral student in the University of Lund in Sweden. And he eventually went on to become a pathologist, but during his thesis work, he performed autopsies on several patients who died from unknown causes and found that they had coexisting cerebellar vascular malformations as well as retinal angiomas that von Hippel had first described, and kidney and pancreas cysts. So together, he put together this syndrome, which would later be called von Hippel-Lindau disease. Harvey Cushing and Percival Bailey would then later call these vascular malformations hemangioblastomas. So as I mentioned before, VHL is a tumor suppressor gene syndrome. It occurs following Knudsen two-hit hypothesis, which is the same thing that happens in NF2. And this means that there's an initial chromosome loss on the short arm of chromosome 3. And in susceptible tissues, those organs I showed you earlier where tumors arise, there's loss of heterozygosity. So both alleles are out for that VHL gene, and this leads to diminished VHL protein. Decrease in VHL protein then leads to diminished degradation, so double negative, of hypoxia-inducible factors. And so this means that there's more hypoxia-inducible factors available, and this leads to increased expression of growth factors like vascular endothelial growth factor. And so there are some interesting phenomena that occur in VHL, which I'll just go over first. So one thing that we found was that tumors can metastasize to other tumors in von Hippel-Lindau, and this is thought that there may be appropriate soil for metastases in VHL in some of these tumors. So this example, which we published 10 years ago, was an epididymal cystadenoma, which was targeted by multiple micrometastases from a renal cell carcinoma. And so the large tissue slice is the epididymal cystadenoma, and all those darkly staining areas are renal cell cancer. Another interesting fact about VHL is that in 2007 as well, it was this disease was related to the Hatfield-McCoy Feud, which is famous in U.S. history. And it turned out in 2007, the group at Vanderbilt discovered that certain descendants of the McCoy family actually harbored VHL disease and had pheochromocytomas. And the idea was that the pheochromocytomas, the catecholamine release, was leading to increased rage and anger in these patients. And that may have driven some of this feud. So now focusing on the neurologic and otologic manifestations, earlier I mentioned these patients develop hemangioblastomas and endolymphatic sac tumors. Hemangioblastomas are fairly common. There's a relatively high penetrance in patients with VHL. However, endolymphatic sac tumors are relatively uncommon. Hemangioblastomas can arise sporadically, and in fact, 2/3 of hemangioblastomas are sporadic, and 1/3 arise in the setting of VHL disease. These tumors typically arise in the retina of these patients, on the spinal cord, typically the dorsal spinal cord, the medullary obex of the brainstem, and the cerebellum. Infrequently, these tumors can occur in the supratentorial space, and most often when that happens, these tumors arise in the optic apparatus, so either the optic nerve or the optic chiasm, or in the infundibulum of the pituitary gland. And the signs and symptoms of these tumors are very specific to the location in which they arise. So you'll have very different presentation from a cerebellar tumor, which typically presents with headaches, versus a spinal cord tumor, which can present with weakness and numbness. These tumors grossly are very vascular, and again, they're secreting increased levels of VEGF and other vascular promoting factors, and they're typically associated with large draining veins, as you can see in this picture on the left. The tumors are benign, and histologically they have vascular cells and as well as clear stromal cells, which make them very difficult to distinguish from renal cell carcinoma histologically. In terms of diagnosis, these tumors are diagnosed using post-contrast T1 weighted MRI, as well as T2 weighted MRI, which can pick up cysts that are associated with these tumors. For screening, these patients should undergo yearly physical exam, and the neurological exam is the most sensitive screening test for triggers for actual treatment for these patients. For MRIs, there are various surveillance guidelines which have recommended starting biennial brain and spine MRIs somewhere between the ages of 8 and 16. However, the optimal age probably should be on the later end of that, because neurological exam can pick up actionable tumors at earlier ages, and we can avoid MRIs in young kids. Once a hemangioblastoma is detected, however, yearly MRIs should be performed. And as I mentioned earlier, these tumors are often associated with a cyst. So in the cerebellum, these are called cysts. In the spinal cord or brainstem, we call these syrinx, or plural syringes. And these cysts are important because they can grow very quickly compared to the tumors. So the tumors have a very steady, slow growth rate. However, the cysts can blossom within a matter of months. And because of this, they're often the most common cause of symptom progression. So how do we manage these tumors? First, the most important thing is identifying the treatment goals. And the treatment goals in VHL are different than the treatment goals for sporadic tumors. So for sporadic tumors, we often like to treat tumors, benign tumors, once they start growing. However, in this case, no treatment is going to be curative. The patient's still going to have other existing lesions. So it's important not to treat the imaging and focus on treating patients when they become symptomatic. There have been natural history studies specifically on the growth of hemangioblastomas in von Hippel-Lindau disease, and these have shown that these tumors don't have a linear growth pattern, but the growth tends to be saltatory, meaning that there are periods of quiescence followed by periods of progression followed by periods of quiescence. So these tumors can be stable for long periods of time, and some of the natural history studies have shown that if you just treat tumors in patients based on radiographic progression alone, this would result in in up to 4 unnecessary treatments within a 10-year period. So in terms of the different options we have for management, the cornerstone of management to date has been surgical management. And our group at the NIH had described the outcomes for large cohorts of patients with VHL and surgery on spinal cord hemangioblastomas, cerebellar hemangioblastomas, brainstem hemangioblastomas, and cauda equina hemangioblastomas. We'll use spinal cord surgery as an example, but to show essentially that this surgery can be safe and effective. In our series of 156 patients, there were a total of 218 tumors that were removed, and we had a complete resection rate higher than 99.5%. Of these 156 patients, 4% were neurologically worse after surgery, but these tended to be tumors that were completely intramedullary and had no presentation to the dorsum of the spinal cord, or tumors that were ventral to the spinal cord. There were complications after 8% of cases, including 4% CSF leak rate. And most of these patients who had cysts or syrinxes associated with their tumors had resolution of the cyst after surgery. In cases where the cyst persisted, it was eventually found that there was another hemangioblastoma that was associated and on the border of the cyst that was driving the cyst formation and production. So just one quick case example of a spinal cord hemangioblastoma that we operated on. This is a 43-year-old gentleman who had worsening back pain, left-sided numbness, and had previously undergone surgery for cranial hemangioblastomas, but not spinal cord hemangioblastomas. So when he presented, he was full strength, but he had diminished sensation on the left side that was worsening, and he was hyperreflexic and had an abnormal gait. So this is his imaging. This is T1 post-contrast MRI, demonstrating a scan from January of the year we operated on him and September, which was immediately pre-op. And this demonstrated a contrast-enhancing lesion within his spinal cord at the T4, T5 level, which nearly tripled in size over 9 months. Which is unusual. Typically, cysts grow faster. There were no cysts associated with this tumor. And when we looked at the axial scans, which is on the right, you can see that nearly the entire spinal canal is involved by tumor. So due to his symptoms, we offered the patient surgery, and he decided to proceed. We took him to the OR for T3 to T5 laminectomies and exposed the dorsum of the spinal cord. When we did this, we found that the tumor was completely intramedullary, so none of it was presenting to the surface of the spinal cord. When this occurs, what we have to do is make a myelotomy or incision in the spinal cord itself. And this myelotomy can be difficult with tumors because the tumors actually expand the spinal cord and distort it and distort its orientation. They can be slightly growing off to one side, and the midline is hard to identify. It's important to make the incision in the midline because that helps us stay in between the two dorsal columns of the spinal cord and prevents neurologic injury. So there's some tips and tricks we can use to try to identify that midline. One is looking for the two dorsal root entry zones and trying to find the midpoint between them. The other is finding small blood vessels that actually travel down into the midline dorsal sulcus. And you can see that on this example. I don't have a pointer, but let's see if this works. Oh, yeah. And you can see these small blood vessels that are traveling into the midline of the area that we're dissecting, this myelotomy. So it's important to make a fairly long myelotomy for a couple of reasons. One, to expose the entirety of the tumor, but also the longer the myelotomy, the more we're able to dissect around the tumor with minimal retraction of the spinal cord, and that can help mitigate neurologic injury after surgery. Unlike most intramedullary spinal cord tumors, where we try to debulk as much as possible so we can minimize the manipulation of the spinal cord tumor or the spinal cord, in these cases we really try to take out these tumors en bloc. And the reason for that is these tumors are very vascular, and getting into the tumor and debulking them can cause bleeding that's very hard to control, and they can make the dissection and the rest of the surgery less controlled. So we really try to take these out en bloc. Another principle of this surgery is we try to save taking the draining vein for the end of the surgery, because if you take the draining vein before taking the arterial feeders, these tumors do tend to expand, and it can actually make the dissection and the removal much more difficult. So this is us removing the cranial pole of the tumor, dissecting underneath it. One aspect of these tumors I mentioned earlier is they're often associated with cysts, and the cysts can actually help in surgery because they create a natural dissection plane between the tumor and the spinal cord or the neural tissue itself. This is now us dissecting the inferior pole of the tumor and then achieving an en bloc resection. So despite the size of this tumor, this patient did very well. He was at his baseline neurological function immediately after surgery, but he did develop a delayed but transient proprioceptive deficit. He was discharged on day 5 with no other issues. So if surgeries are gold standard or first-line therapy, what do we do for patients who are not candidates for surgery? And this could include patients who are medically unfit, patients who have extensive systemic disease, and again, these patients develop renal cell carcinoma, which can not only is cancer and can metastasize, but can lead to the need for nephrectomies and then renal issues. These patients also can have extensive central nervous system disease, which gets to the point where there are too many large hemangioblastomas in unsafe locations to offer surgery. So we need some alternatives for these patients. One option is stereotactic radiosurgery, which we looked at a few years back, and in a cohort of patients who were following prospectively at the NIH who had von Hippel-Lindau disease, we followed 20 patients who had 44 tumors that were treated with stereotactic radiosurgery. There were no complications in this cohort, but unfortunately, the tumor control continued to diminish over time to the point where the 10-year progression-free survival was 61%, and the 15-year progression-free survival came all the way down to 47%. So we weren't sure if we were actually bettering the natural history of these tumors. Furthermore, the small asymptomatic tumors that were treated in this cohort, so these are tumors that are less than 1 centimeter in size, also grew in some cases after this radiation therapy. So this suggested to us that prophylactic treatment of hemangioblastomas with radiation therapy may not be a good idea. There are now some medical options for these patients with hemangioblastomas. There was a recent study at MD Anderson which used a drug called pazopanib, which is an oral tyrosine kinase inhibitor, in 37 patients given over a 24-week period. They found, so in addition to responses in the kidney and pancreatic tumors, these 37 patients harbored 49 patients, of which only 2 had objective responses. However, that wasn't the entire story, as you can see in this waterfall plot demonstrating the growth before and after treatment. A large majority of these patients, or these tumors, actually diminished in size after therapy, although they didn't reach the RECIST criteria for an objective response. There were 3 severe adverse events in this cohort of 37 patients, and this included 1 patient with appendicitis, 1 with gastritis, and 1 patient who had a fatal CNS hemorrhage. We've had, our center has also had some experience with these, with pazopanib for VHL and hemangioblastomas, and we recently reported a case of a patient who had variable response to pazopanib, meaning that some of his tumors actually responded to the therapy and some did not. So this spinal cord tumor, which was at the C7T1 level, had a pretty striking response in his the portion of the tumor that was within the spinal canal. So that this is before treatment and this is after treatment, and so this part shrunk, but then the part within the neural foramen did not change, and his cerebellar hemangioblastomas did not change as well. So in summary, for the hemangioblastomas, the majority of these patients with VHL do develop hemangioblastomas. And patients for screening should undergo yearly neurological exams and also MRIs for surveillance once they reach adolescence. The symptoms from hemangioblastomas are most often due to cyst or a syrinx in the spinal cord. And the optimal management paradigm is to treat these tumors as they become symptomatic. Surgery should be the gold standard in the first-line therapy, and it's generally safe and effective. Radiosurgery can be a salvage option, but should definitely not be used prophylactically. And medical therapies are an option. Pazopanib is promising, specifically when surgery is unfavorable, but also this medical therapy has or the possibility of treating both the central nervous system disease and the systemic disease at the same time. So in a patient who has extensive CNS and systemic disease, this may be a reasonable option. So we're going to switch gears and talk about the otologic manifestations of von Hippel-Lindau disease, which are endolymphatic sac tumors. And these weren't termed endolymphatic sac tumors when they were first described. They were initially described as adenomatous tumors of the middle ear. And this encompassed more than just endolymphatic sac tumors, but this was the category under which they fell. Gerlach at Northwestern had described a series of 3 patients who had these tumors at the middle ear. And it wasn't until 1989 where it was proposed that these tumors may be arising from the endolymphatic sac. And this was performed at the Armed Forces Institute of Pathology by Dennis Hefner. In fact, these tumors are initially called by some Hefner's tumors, but they later were widely accepted as endolymphatic sac tumors. During the 1990s and 2000s, encouraging results from the House Clinic demonstrated that surgical management could be safe and effective. And this included papers by John House, Dr. Brackman, Bill Luxford, demonstrating that these tumors could be removed and provide good functional outcomes for these patients. During the 1990s, however, there were some case reports that showed temporal bone tumors in patients with von Hippel-Lindau disease. And it wasn't until 1997 when Ed Oldfield at the NIH showed that, or systematically analyzed this and found that 11% of patients in VHL had temporal bone tumors. Of these 13 patients in his cohort, all 13 had hearing loss, and the majority had either tinnitus or both tinnitus and vertigo. However, facial weakness was relatively uncommon in this cohort. In this cohort of 121 patients, there were an additional 8 patients who had hearing loss that was consistent with an endolymphatic sac tumor, or ELST, but had a negative MRI. And so the total incidence of endolymphatic sac tumor in this VHL cohort was somewhere between 11 and 17%. And I included this table on the right from their paper, which demonstrated that these tumors could be quite small and still cause functional hearing loss. So getting at the mechanisms of why these patients lose hearing with ELSTs in von Hippel-Lindau disease, specifically because these tumors can be, people noticed that these tumors could be quite small and cause hearing loss. Russ Lonser and colleagues looked at a cohort of 35 patients who had 38 endolymphatic sac tumors to specifically address this question. They found that 31 had some form of hearing loss. However, only 7 of the 31 had erosion of the oda capsule, which could directly explain that hearing loss on MRI. And so you can see this example on the right from their report, which demonstrates a large endolymphatic sac tumor extending into the posterior fossa, but then also eroding the inner ear structures. Of the 31 patients, an additional 11 patients demonstrated hearing loss with intralabyrinthine hemorrhage, but without significant bony erosion. And this can be seen on this image on the right, where you have the CT up top demonstrating no significant erosion by the tumor, and the tumor is where this little arrow is. And then on pre-contrast T1 weighted imaging and FLAIR imaging, there's hyperintensity within the vestibule, which is consistent with hemorrhage and likely the etiology of the hearing loss. There were an additional 14 patients in this cohort who developed gradual hearing loss, did not have intralabyrinthine hemorrhage, did not have significant bony erosion, and also had demonstrated tinnitus and vertigo. These patients who had Meniere's-like symptoms were thought to have endolymphatic hydrops. And in fact, when the same group from the NIH looked at a post-mortem study of a patient who had hearing loss with VHL, they did find pathologic findings, histopathologic findings that were consistent with endolymphatic hydrops. So this is a tumor within the endolymphatic sac and the duct going off to the right here. And in this lower image, we can see near the region of the footplate of the stapes, we can see a severe dilation of the cochlear duct. So how do we diagnose and manage these patients? Again, as I've shown, not all patients with endolymphatic sac tumors will have MRI findings. Audiograms are really the most sensitive test for findings that would necessarily be actionable and require treatment. So screening guidelines to date have recommended starting biennial audiograms at age 5. But we're considering a revision of these guidelines to perform, getting more frequent audiograms and getting yearly audiograms in these patients. Additionally, thin slice MRIs should be performed in conjunction with the MRIs that are already being obtained for surveillance of hemangioblastomas. In terms of management, the goals are twofold. So for small tumors, the goal is hearing preservation, and for larger tumors, the goal is local control because these tumors can invade sensitive neurovascular structures like the facial nerve and carotid artery. Hearing rarely improves after treatment, so because of this, it's important to act on these tumors early. And the tumors should be resected as they are identified. So this goes against what we recommend for hemangioblastomas, where we only want to operate on these tumors as they become symptomatic. So a lot of our information on the outcomes of management for ELSTs, specifically in VHL, come from the NIH. And the largest series of ELSTs operated on in VHL was performed at the NIH by Jeff Kim, who presented his outcomes as a Triological Society thesis. And he reported the results of 33 operations in 31 patients with ELST, of which 4 were MRI negative. 28 of these 31 patients had hearing loss, and these tumors were generally small, so some were as small as 2 millimeters in size. Complete resection was achieved in 30 of these 33 cases. However, 3 tumors encased the carotid and small tumor was left adjacent to the carotid. And additionally, in 2 cases, there was tumor near the facial nerve that was left. In terms of audiologic outcomes, 31 patients had full audiologic data, and of these, 27 remained stable after surgery, 3 improved, and 1 worsened after surgery. Vertigo improved in all patients, but resolved in the majority, and tinnitus improved in the majority of patients. Facial weakness was present in 4 patients before surgery and improved in 3, and the House-Brackman grades are listed here on the right, before surgery and after. Complications occurred after 3 surgeries, and this included 2 CSF leaks, and 1 patient who had a very large tumor extending down to the jugular bulb had a transient glossopharyngeal and vagal nerve palsy. In terms of alternative therapies, to date there's really no evidence-based support for either radiation therapy or medical therapy. There was a recent systematic review on radiation therapy for endolymphatic sac tumors, which showed an overall tumor control rate of 67% at last follow-up. But when we looked at, the authors looked at the Kaplan-Meier analyses for stereotactic radiosurgery out at just 5 years follow-up, the tumor progression-free survival was around 60%, and it was around 50% for conventional radiation therapy. So again, in this case, we don't know if this treatment is actually bettering the natural history of these tumors. And so far, no medical therapies have been applied for endolymphatic sac tumors in von Hippel-Lindau disease. So in summary, for the endolymphatic sac tumors, a minority of patients with von Hippel-Lindau disease will develop these tumors and/or hearing loss. We recommend that patients undergo yearly audiograms, and the hearing loss in these patients is typically related to either bony erosion, intralabyrinthine hemorrhage, or endolymphatic hydrops. These tumors, unlike hemangioblastoma, should be treated when they're detected because hearing loss is unlikely to improve with treatment. So we want to treat them as soon as possible. And then finally, surgery is generally safe and effective and should be the first-line therapy, whereas radiation and medical therapies haven't been borne out as being safe or effective. So finally, I'd just like to thank two of my surgical mentors who have really helped shape the field of VHL and were responsible for the majority of those papers I presented. On the left is Ed Oldfield, who was chair of the Department of Neurosurgery at the NIH for 25 years, and then worked at the University of Virginia for an additional 10. He passed away last year. And Russell Lonser on the right, who is chair of the Department of Neurosurgery at the NIH for 5 years and has been chair at Ohio State for the last 5 years. And that's all I got. Thank you.
I remember the first case I had, and I recognized it. A young lady came in with what appeared to be typical Meniere's. And she'd been seen elsewhere, but the obvious thing was that the hearing had gone down almost completely. But then she developed facial weakness. And that's when we, at that time we didn't have MRI, but the CT scan showed this moth-eaten bone. And the thing I remember about operating on several of these is that they really do bleed.
Yeah. And it's because of the pathophysiology of these tumors. You know, there's decreased downregulation of HIF, the hypoxia-inducible factors, and more VEGF. So biologically, they have dysregulated vasculature, and they're vascular tumors by nature.
So should a person who has an endolymphatic sac tumor be screened for renal cell carcinoma?
So so von Hippel-Lindau disease is relatively rare. It occurs in 1 in 39,000 individuals. But even within von Hippel-Lindau disease, endolymphatic sac tumors are fairly rare. So that hasn't been, there are no specific guidelines on that, but I think it's still unlikely that, that these patients will have von Hippel-Lindau disease. If you have a CNS hemangioblastoma, on the other hand, 2/3 of them arise, or sorry, 1/3 of them arise within the context of von Hippel-Lindau disease, so they should definitely be screened for von Hippel-Lindau disease.
It was a great talk. Any difference in the natural history of ELSTs in VHL versus sporadic ELSTs?
So it's unknown yet, because again, the association between VHL and ELSTs was only established in 1997. But what we do know, and the other side to that is a lot of these ELSTs have been treated very early after detection. So there really isn't time to define that natural history. But we do know that unlike the hemangioblastomas, which usually don't cause symptoms when they're very small and they're not associated with a cyst, these tumors can cause symptoms when they're very small.
And then following up on that point, so you recommend annual audiologic surveillance for patients with von Hippel-Lindau disease. Presumably a patient that presents with unilateral hearing loss who has a known diagnosis of von Hippel-Lindau will then merit CT temporal bone or further
Yeah,
investigation
exactly.
of that ear? And what do you recommend if those studies are negative, or what is the workup or surveillance in that scenario?
Right,
specifically?
and so that's very difficult. So if so after the MRI, then the next step exactly is that CT of the temporal bone to try to pick this up. Then the question is, do you do an exploratory surgery or just follow the patient? So there's certain clues that can kind of add into the picture of this. If they have Meniere's like symptoms, low frequency hearing loss, then maybe it fits better with an endolymphatic sac tumor. If their symptoms are getting worse over time, then the paradigm at the NIH has been to operate on them even if they're imaging negative.
So for exploratory.
Yeah, and that's and so I showed you in that series some of the tumors were 2 millimeters in diameter.
Yeah, okay.
Those were not imaging positive tumors. Those were tumors that when they were exposed were found to be essentially microscopic. Yes, Tommy.
You showed that histologic slide of a tumor metastasizing into another
Oh, yeah.
tumor. And you said the other tumor site may be fertile soil for the other tumor to grow. So what's the thought on that? Are there extracellular things? Is this known to happen in other syndromes?
So I haven't seen this in other syndromes. The group at the NIH had reported tumor metastases to hemangioblastomas as well. So there was a cohort of, it was more than 10 renal cell and 1 pancreatic islet cell tumor metastasizing to CNS hemangioblastomas. And in fact, one of the patients in the spinal cord hemangioblastoma series I reported had renal cell met to hemangioblastoma. I think what's happening in this is these tumors are secreting these vascular growth factors. So even this epididymal cystadenoma is secreting these high levels of these growth factors, and these growth factors will help the metastases kind of take hold and eventually expand in this area, because all these metastases start with just a cell or two. And so this concept has been around for a long time, and I think it was in the late 1800s. Paget had described the seed and soil hypothesis, that metastases are really looking for, they can go anywhere in the body, but it really requires the right soil for them to take hold and grow into real sized tumors, or gross tumors.
Very good.
Thanks, guys.
Very good. Well done.